but if I could just get a very brief answer from each of you on the general question, Riyaz, you brought up in my heart of hearts or something like that. I think that if patients can have surgery, they should. We have older data that looked at patients who would potentially go either way that showed essentially equivalent survival for chemoradiation versus chemoradiation followed by surgery. And that was before adding immunotherapy for the non-surgery patients that really improved survival. I would suggest that we shouldn't think of non-surgical management as a consolation prize necessarily. And I'm just interested, to me, that the results with durvalumab immunotherapy kind of tip the scale that if you need to shoehorn a patient into surgery, you shouldn't necessarily force that issue, because the non-surgical approach has improved and is not a bad option. And I just want to get your sense of, whether that's valid, or any other folks about, whether surgery is by all means what you should do if some surgeon says they will.
So my view on this, I entirely agree. I think non-surgical treatment of early lung cancer has come on so much that you can start questioning what is the role of surgery effectively. The reality is, in my practice, in my clinical experience of meeting patients, this isn't generally a question that comes up, because patients generally fall into different groups quite easily. Most people that get diagnosed with early lung cancer, who are fit, who have no comorbidities, in good physical state, there are some who will decline surgery. I've met people who are just terrified of the thought of undergoing surgery for actually very resectable disease, but vast majority do go and have surgery. And the majority of patients that, often patients with high comorbidity indexes who wouldn't be very good for surgery, don't often come to our clinics touting for surgery. They often are very hesitant about surgery because they know that there's a chance they may not make it through. So I think actually generally it's not, in clinical practice, patients just fall into these groups naturally. It's quite clinically obvious what the right thing to do is for that patient. And the number of patients where this is a real, genuine discussion is actually fairly small. And I just don't think we have that level of data to, there's no simple answer to this. You just have to put all your cards on the table with the patient, with all the relatives. Sometimes we have patients go and have a radiation oncology appointment, go and have a surgery appointment, wait a week or two, think it through, see them again, and they'll make a decision.
I think you also raise a great point that we haven't articulated here, which is stage 3 is a very heterogeneous group for lots of reasons. The extent of disease, the characteristics of the disease, the features of the patient, their comorbidities, which is other medical issues, their place socially. I mean, all of these issues are very important factors that speak to the heterogeneity. So it really doesn't make for quick rules. Estela, can I get your thoughts on?
I mean, I agree with everyone that this is why we have multidisciplinary conferences really to discuss stage 3 disease, and patients do have their preferences, and we need to kind of start there, what the patient's preference is. But I will say that for stage 3 disease, we do draw the line. Like if you have bulky disease, multi-station disease, our data suggests that you're going to recur most likely systemically. So that's why we kind of favor an approach that has immunotherapy consolidation if the patient is a candidate, because the systemic recurrence is really what we're trying to prevent.
Narjust, any different perspective here?
No, really. I think, it is, because what it can be a good option for one patient can be a horrible option by another.
So it depends. Yeah.
It depends. But I think everyone, I think not only the surgeons, the radiation oncologists, we have something called pre-rehabilitation that some of these patients that are a little bit older can be on before surgery. So they pre-rehabilitate as you do all the other work. That has really, allowed for these patients to tolerate surgeries that can be significant. And we need to, remember that pneumonectomies are high mortality, high morbidity, and these patients are never the same after a pneumonectomy. Like that nerve pain can stay there for a year or two.